Okay, so looks like everyone's joining. Good morning, everyone. Thank you for joining us this morning. Today, I am thrilled to be welcoming my friend, Evan Noch, who joined the Department of Neurology and the Division of Neuro-Oncology just last year. Evan started his education right here in New York City at NYU, where he completed his BS in neuroscience. And then he went back to Philadelphia, where he's from, where he received his MD and PhD in biomedical neuroscience at Temple. He then came back to New York for his neurology residency here at Cornell, after which he completed a 2-year fellowship in neuro-oncology at Memorial Sloan Kettering, during which time I had the distinct pleasure of working with him as a fellow. He was luckily then corralled back to Cornell, and he's now pursuing a tremendous amount of research. In addition to his rigorous academic pursuits, he did not stop there. He is the co-founder and CEO of D-Stroke Incorporated, and that is a company that tries to empower patients to detect clinical stroke using a mobile app, and that directly communicates their NIH stroke scale to EMS and healthcare providers. So his work has just been launching this year, and we're excited to see where it goes. He was also awarded the Society for Neuro-Oncology Young Investigator Award in 2019, and his research is further supported through the NCI and foundational grants. His research has really been focused on glioblastoma, and he is helping us rethink how we work on metabolic therapies and the role of diet in glioblastoma treatment. Evan, it's wonderful to see you again, and welcome.
Thanks for the great introduction. Thanks for the invitation to speak today. So I guess I will share my screen. Okay, can you guys see that okay? Okay.
Perfect.
Okay, great. All right, well, hello everyone. My name is Evan Noch, and I'm gonna talk to you today about some of my work in the lab to leverage synergistic metabolic therapies in GBM, mostly looking at PI3 kinase inhibitors and the ketogenic diet. So as Rupa mentioned, I'm the co-founder and CEO of a stroke detection startup, D-Stroke, but I won't be talking about any of these aspects of the company today. So we all know that in GBM, there have been many therapeutic strategies used in recent years. These include standard cytotoxic chemotherapy and radiation, more recently tumor treating fields, immunotherapy, small molecule inhibitors, oncolytic viruses, and dietary therapies. Now, there haven't been many advances in the field of GBM for really over 15 years, potentially with the exception of tumor treating fields. And I'll talk about some of the reasons why that's the case today. But for this presentation, I'm going to focus mostly on small molecules and dietary therapies that we've been working on in the lab. But why have these small molecule treatments mostly failed? We all know most of the reasons. These have to do with aspects of tumor heterogeneity, both intertumoral heterogeneity, where tumor initiating cells can actually differentiate into a heterogeneous population that can then go on to initiate the tumor. Also some intratumoral genetic heterogeneity, where tumor initiating cells can become heterogeneous within the same tumor bulk. And we all know that from some of the studies showing that IDH and EGFR amplifications or mutations are heterogeneous within a single tumor. In addition, we know that there are several different factors within the tumor microenvironment itself, like secreted factors that lead to tumor heterogeneity, as well as hypoxia and necrotic niches that promote heterogeneity, and also inflammatory cascades, such as cytokines or immune cells that can promote heterogeneity within the tumor. We also know that many of the drugs that we use in other cancers don't cross the blood-brain barrier and can't lead to therapeutic efficacy. This is due in large part to various aspects of the blood-brain barrier, including tight junction regulation, regulation of export proteins such as P-glycoprotein or the ABCD cassette, and also aspects of the blood-tumor barrier, including tight junction proteins and proteins that prevent the permeability of this barrier to our drugs. In a study from Stu Grossman and J. Street Blakely, they showed that there's also heterogeneity with the tissue-to-blood concentration of various cytotoxic chemotherapy drugs and small molecules that are used in GBM patients. And this makes us wonder, well, what concentration of these drugs is important to actually achieve therapeutic efficacy in the brain? And how can we leverage these aspects of blood-brain barrier permeability to make sure that the drugs we use do cross the blood-brain barrier and achieve therapeutic efficacy? And finally, there are various resistance pathways. And this is probably no more true than in all the failed trials that have recently occurred in the EGFR domain. And this is due in large part because there are resistance pathways to EGFR, for example, other receptor tyrosine kinases like PDGFR. And also on the right, we know that many different tumor clones that have EGFR amplification or mutation carry other co-mutations, such as that in the PI3 kinase or PTEN pathway, CDKN2A pathway, and other pathways such as P53 and MDM2. But also in GBM, metabolic therapies with small molecule inhibitors and other regimens have also recently failed. This is true for aspects of glutamate signaling with telampanel, which targets the AMPA receptor in a large phase 2 study of 72 patients. In this study, the median progression-free survival, median overall survival for these patients was 20 months versus 16 months, but failed in a large phase 3 study that was multi-institutional. In addition, telampanel was tried in a population of 30 recurrent malignant glioma patients, but was not efficacious in this domain. And also sulfasalazine, which is an inhibitor of glutamate transporter XC, also failed in an early phase study of 10 patients. Now, there are other aspects of glucose signaling that were tried as well in recurrent glioma patients, including ritonavir, which we know is used to treat patients with HIV. Now, ritonavir also can regulate the expression of glucose transporters, and this failed in clinical trial, as well as disulfiram. So disulfiram is a drug that's been used for alcohol abuse, known as antabuse, but can also regulate PHGDH, which is one of the rate-limiting enzymes in serine biosynthesis. Now, this also failed in a population of 12 patients in early phase studies with virtually no responses seen. Now, one of the main reasons for these failures is that GBM, we know, can consume many different nutrients. So if you starve a tumor of glucose, the tumors are very happy to take up other amino acids such as glutamate or glutamine, or even fatty acids. So if you only block one pathway, these tumors have many different nutrient availabilities that they can use to perform anaplerotic metabolism. Schematically, this can be shown here where we see the main routes of entry through glucose, glutamate, and glutamine in these tumors. So in normal states, these tumors can take up nutrients through all of these pathways. And if you block glucose uptake, for example, 2-deoxyglucose has been used, and other inhibitors of glucose uptake, the tumors are very happy to take in glutamate and glutamine to fuel mitochondrial metabolism and even perform gluconeogenesis to maintain the Warburg effect. Now, there are many different drugs in trials to help block some of these aspects of signaling, but unless we block multiple aspects or routes of metabolism, we won't achieve therapeutic efficacy because of all these resistance pathways that can bypass any single target. So we know all the targets in cancer, but they just need to be validated. This was once told to me by Danielle Cielo from Pfizer. But I'll modify this by saying that actually these targets need to be rationally combined. It's not enough to validate the target in GBM because we know that these tumors will not be sensitive to any single agent. So for these tumors, we must leverage the main mechanism of resistance, and I'll talk about that with PI3 kinase and the ketogenic diet. Ideally, these two therapies or multiple therapies should be synthetically lethal, and we must leverage the tumor more than the normal cell to inhibit some of the side effects that we see in our brain tumor patients. So I'll give an example that we've been working on in the PI3 kinase pathway. This pathway begins when the ligand insulin binds to the insulin receptor. This recruits PI3 kinase to the cell membrane, where it phosphorylates PIP2 to PIP3. Now, PIP3 then recruits PDK1 to the cell membrane, where it phosphorylates AKT. And AKT then leads to a host of downstream signaling pathways that regulate glucose uptake and growth through TXNIP and mTOR. This pathway is intrinsically linked to aspects of glucose metabolism because it begins with the ligand insulin. And so regulation of this pathway through aspects of glucose modification can also modify the function of this pathway itself. So for the ketogenic diet, which some of my colleagues have worked on in lab, We know that this diet is a diet of 4-to-1 ratio of fat to carbohydrate and protein. And typically in clinical trials can be around 1,600 to 1,800 calories, depending on what a patient can tolerate. I will say that the 4-to-1 ratio can be somewhat difficult for patients, and so oftentimes in clinical trials, this is modified to a 3-to-1 diet to reduce the amount of fat. This diet works by depleting hepatic glycogen, thereby reducing serum glucose, which leads to about a 10 to 20% reduction in serum glucose and modest weight loss of 10%, which is why some people use this for health maintenance. Now in GBM, the ketogenic diet has been tried in about 7 studies so far. Some of these were very small early phase pilot studies and others were somewhat larger. But for the most part, most of these studies have failed to show any large effect, and they all have been pretty small studies anyway. There haven't been any large randomized multi-center studies to look at the ketogenic diet. But one of the issues with the approach used in the literature is that in most cases, this diet has been used in isolation. Now we know that with only a 10 to 20% reduction in serum glucose, and by depleting some of the hepatic glycogen, this diet would only lead to moderate changes in glucose metabolism by the tumor, and the tumor would have many mechanisms to bypass the action of this diet. So to look at the combination of PI3 kinase inhibitors and the ketogenic diet in tumors, one of my colleagues, Ben Hopkins, looked at suppressing insulin feedback that's caused by these PI3 kinase inhibitors. He used a variety of cancer models, first including the KPC model in the pancreas. And these animals in brown that were on the ketogenic diet, as well as BYL719 or alpelisib produced by Novartis, showed much less tumor growth than any of the other animals in this study. In addition, this was also true for endometrial PDXs, where in purple, animals on BKM120, which is buparlisib and the ketogenic diet, exhibited much less growth compared to the other animals. And for the pancreas model, this led to prolonged survival of about 40 days for the last animal in the ketogenic diet group compared to all the other groups. Interestingly, this was also true for animals who were treated with metformin, the anti-hyperglycemic drug used in diabetics, as well as SGLT2 inhibitor, or canagliflozin, or Invokana as the brand name, that's used to prevent glucose uptake by the kidney. Now the mechanism here is that PI3 kinase typically leads to glucose mobilization, and also in the liver, glucose can be converted to glycogen by PI3 kinase. But in the presence of the inhibitors, these inhibitors lead to mobilization of glucose from the liver, which can then stimulate the pancreas to produce insulin. On the other hand, when animals are treated with the ketogenic diet, hepatic glycogen is reduced, and that then reduces the feedback of glucose on the pancreas to prevent the secretion of insulin caused by PI3 kinase inhibitors. Now, this has been well known in clinical studies because patients who are treated with PI3 kinase inhibitors exhibit on-target treatment-related hyperglycemia. But insulin is tending to be used in these trials. That's because in patients who are admitted, insulin is very easy to use. The hyperglycemia can be really bad. It can be 300s to 400s. And it's very common when patients are in the hospital to hold oral anti-hyperglycemic drugs. But we know from our studies that insulin is really the antidote to PI3 kinase inhibition because it reactivates the pathway through the ligand receptor pathway that I just mentioned. In GBM last year, a study in buparlisib in GBM patients was conducted by Patrick Wen and Keith Ligon up at Dana-Farber. Now in this study, there were 2 cohorts. There was a surgical cohort of 15 patients who received buparlisib 5 days before treatment with surgery, and then were followed prospectively with daily buparlisib treatment. There was also another cohort that did not receive surgery, but that received buparlisib and was carried forward to 50 patients. Now they measured the concentration of buparlisib in the surgical tissue after treatment with buparlisib using mass spec. They found that buparlisib did actually reach the tumor tissue and that there was no significant difference between the concentration in non-contrast enhancing tumor versus contrast enhancing tumor, indicating that it didn't have to do with blood-brain barrier breakdown or permeability that allowed the drug into the brain. When they looked at activation of the PI3 kinase pathway, they found that buparlisib, in comparison to archival specimens not treated with buparlisib, had lower levels of phosphorylation of AKT at serine 473, indicating that this drug hit the target and achieved a knockdown of PI3 kinase signaling. However, when they looked at phosphorylation of S6 as serine 235, 236, they found that there was no significant difference. And S6 is another downstream partner of the PI3 kinase pathway through mTOR, indicating that in this study, they only achieved incomplete inhibition of this pathway. Now, one reason for this may be that many patients in this study experienced treatment-related hyperglycemia. While the study only showed that 3 patients experienced grade 3 or 4 treatment-related hyperglycemia, 50% of patients in cohort 1 had hyperglycemia and 40% of patients in cohort 2 had hyperglycemia, and this was of any grade. Now, keep in mind that fasting glucose levels in grade 1 can be around 160 or a little bit less, and in grade 2, they can be between 160 and 200, which would make any of us feel pretty crummy. So it's possible that in this study, though there were only few patients who had treatment-related hyperglycemia of grade 3 or 4, the large amount of hyperglycemia in the lower grades may have led to incomplete inhibition of this pathway through feedback of insulin signaling. Needless to say, this was a negative study with no complete responses or partial responses, and only a few patients with stable disease, leading to an overall median progression-free survival of less than 2 months. Now, other studies have also been conducted. Now, this study in breast cancer with alpelisib, produced by Novartis in hormone receptor positive advanced breast cancer, was a positive study. This was a SOLAR-1 study. So what was the difference in this study compared to how the Beparlib study was conducted? Well, for this study, the study investigators consulted Lou to act as a formal study advisor. Now, in order to act as a study advisor, Lou insisted that no one in the study be given insulin and continue treatment. So what the mandate was that if you needed insulin in the acute phase, that was permissible. But if you required further insulin in the chronic phase because of treatment-related hyperglycemia, you were taken off study. And that was to minimize some of the side effects that would be due to insulin and also potentially abrogate the study efficacy. So only patients in this study were given metformin as the main anti-hyperglycemic drug. And if they needed insulin, then they were generally taken off study. What were the results? Well, with no insulin given, this was a positive trial and led to FDA approval in May of last year. So now this drug is now being tested in a variety of cancers, along with strategies to minimize this insulin feedback using anti-hyperglycemic drugs, mostly metformin or canagliflozin. In glioma, we know that the PI3 kinase pathway is directly altered in about 10% of patients and is also activated in 80% of patients due to alterations in PTEN. So this makes PI3 kinase inhibition an attractive strategy to target this pathway in glioma. But we know that hyperglycemia is the main side effect. We know from our laboratory studies that this can lead to feedback activation, but also from literature in neurodegenerative diseases that hyperglycemia can lead to neuroinflammation, potentially also worsening morbidity for these brain tumor patients. So our strategy would be to minimize the feedback that reactivates this pathway and also to minimize neuroinflammation. We hypothesized that the combination of PI3 kinase inhibitors with glucose starvation would lead to decreased growth as well as decreased neuroinflammation in these tumors. And then that would also reduce morbidity and also reduce mortality associated with GBM. So what we first did was we looked at some anti-hyperglycemic drugs in vitro. For these studies, we used patient-derived glioma cells, 603, the anaplastic oligodendroglioma cell, and 667, the GBM cell. These were obtained from Cameron Brennan at MSK. So in these studies, we treated these cells in culture with fenformin, which acts like metformin as a complex 1 inhibitor of the mitochondria, as well as BKM120, the pan-PI3 kinase inhibitor, or BYL719, the alpha-specific inhibitor. So for these studies, what we saw was that when we treated these cells with the PI3 kinase inhibitors, we saw a decreased phosphorylation of AKT, as we would expect, both in the 603 cells as well as in the 667 cells. And we saw activation of AMP-activated protein kinase, which responds to glucose-altering drugs, as we expect. This combination of drugs led to changes in cell growth in a dose-dependent fashion when treated with fenformin, as you can see by the red arrows here, indicating that there's some synergism in culture with drugs that actually alter glucose metabolism with PI3 kinase inhibitors. Looking more at the neuroinflammatory phenotype in vitro, we looked at how BKM120 in combination with fenformin would alter the production of pro-inflammatory, anti-inflammatory cytokines. For these studies, what we saw in turquoise was that when we treated these cells with BKM120, we saw increased production of several pro-inflammatory cytokines in almost all the conditions tested. But then when we added fenformin, these levels were reduced to close to baseline, indicating that fenformin may actually counteract the effect of BKM120 in the production of inflammatory cytokines. To study this further in vitro, we used a conditioned medium model. For this model, we treated glioma cells with PI3 kinase inhibitor, and then harvested the conditioned medium and added it to cortical neurons in culture to see if there was more inflammation in these cortical neurons from glioma cells treated with PI3 kinase inhibitors. In these studies, what we saw was that BKM120 and to a larger extent BYL719 led to increased levels of both superoxide and total ROS in these cells, indicating that there is a secreted factor in cells treated with PI3 kinase inhibitors that can be neuroinflammatory. Moving to some of the in vivo studies, what we did was we treated animals with our PI3 kinase inhibitors, just as my colleague Ben had done earlier in the laboratory. As seen before, BKM120 causes treatment-related hyperglycemia that can be abrogated by treatment with the ketogenic diet close to control levels. Now, interestingly, the SGLT2 inhibitor Invokana or canagliflozin, when it's used in pre-treatment with BKM120, can also suppress the treatment-related hyperglycemia induced by BKM120 back to near normal levels of between 100 and 200 in these animals. And just to confirm that animals who are given the ketogenic diet exhibit ketosis, we measured beta hydroxybutyrate in these animals, and we see that animals treated with BKM120 on a ketogenic diet exhibit these levels above 1, an indicator of ketosis, whereas animals treated with BKM120 or vehicle exhibit levels more that are normal. When we looked at functional mechanisms of how glucose is modulated in these tumors, we used FDG PET imaging. So on the left, what we can see is animals treated with vehicle who exhibit baseline levels in FDG avidity. But then with the ketogenic diet, we see this interesting increase in FDG uptake. Now, we hypothesized that this was due because these animals are very insulin and glucose sensitive as a result of being on the ketogenic diet and having less glucose around. And so when you give them the FDG load, they exhibit robust glucose uptake. This is in contradiction to BKM120. These animals exhibit much less glucose uptake with FDG. And we hypothesized that this was due to the fact that these animals have normal non-radioactive labeled glucose around. This non-radioactive labeled glucose competes with FDG, leading to less uptake in animals treated with BKM120. But when you combine the two treatments, this normalizes back to control. And this is quantified here on the right. So these studies indicate that the ketogenic diet can normalize the changes in glucose metabolism that are induced by BKM120 in these animals. So what effect does this diet and the use of PI3 kinase inhibitors have on the growth of orthotopic xenografts? For these studies, we implanted these xenografts into the brains of NSG mice and tracked them over time, performing bioluminescence imaging 3 weeks after tumor induction. In these studies, we see that the ketogenic diet has relatively a minimal effect on the bioluminescence intensity of these animals. BKM120 has a pretty significant effect alone, which we've seen in prior studies, but the ketogenic diet in combination has the largest effect, which is shown here in the images on the right. This led to changes in overall survival in these animals, with our BKM120 leading to some increase in survival, but the ketogenic diet in combination with BKM120 leading to even more increased survival, with animals living up to 40 days, almost double the length of time that animals treated with vehicle or the ketogenic diet survive. So these studies suggest that not only can the PI3 kinase inhibitors act alone and have some efficacy in these tumors, but that the efficacy is significantly enhanced by combining these inhibitors with the ketogenic diet, both for functional glucose uptake, for growth, and for survival. So the conclusions from this part of the study are that PI3 kinase inhibitors with fenformin in vitro can lead to decreased growth of these tumors, decreased production of inflammatory cytokines, and that the PI3 kinase inhibitors combined with the ketogenic diet can also lead to decreased growth of these intracranial GBM patient-derived xenografts, which we hypothesize can promote the strategy of glucose starvation and enhance the clinical efficacy of these inhibitors. Now, the future directions from this part of the study are that we will then confirm the PDX work with our genetically engineered mouse model. These models we're obtaining from Eric Holland's lab out at Hutch. And we will confirm that the PI3 kinase inhibitors lead to better pathway inhibition with the ketogenic diet by immunohistochemistry. For our neuroinflammatory work, we're measuring the cytokines in the cerebrospinal fluid in the immunocompetent genetically engineered mouse model with the PI3 kinase inhibitors in the ketogenic diet. The function of this will be that we can see if there are any changes in the production of these cytokines in the CSF, and then whether we can modulate that with any additional changes in these pathways in the tumor cells themselves. And we'll also measure immune cell infiltration in the PDX tissue with or without the PI3 kinase inhibitors. So this also begs the question, well, what happened in the buparlisib study? Why did this study mainly fail? Now, did the trial fail because there was too much hyperglycemia, which led to incomplete inhibition of the pathway, as I showed with the phospho-S6 data? So what we're doing is we are conducting an IRB approved study here with an MTA with Patrick Wen and Keith Ligon up at Dana-Farber to reanalyze the data in this trial. So what we're trying to do is see if we can correlate the glucose levels with overall survival in the study. Perhaps some of the patients who didn't survive as long actually did have higher glucose levels when they were tested in the study. And then there may have been a signal if they had actually stratified the patients by glucose. Also, we're obtaining archival tissue from that study, comparing it to historical control tissue here to see whether there's any changes in tumor-associated immune cell infiltration with buparlisib treatment. So in the patients who received buparlisib, were there more T cells, NK cells, macrophages in these tumor samples? And what is the phenotype of those cells? Were they more pro-inflammatory, anti-inflammatory? And how might that have also affected the survival within the study? And we'll also look at markers of neuroinflammation in buparlisib-treated patients to see whether these patients treated with buparlisib exhibited more inflammation that could then have also worsened their overall survival or potentially their morbidity. So I guess I went through that relatively quickly, but I'd like to thank Lou, who's been advising me on these projects for the past couple of years, as well as the technicians working with me, Laura Palma and Isaiah Yim, as well as Matt Fink from Neurology and Richard Isaacson for their support, my mentor at the BMRI, Kaze Adekola, as well as collaborators at Dana-Farber, Patrick Wen and Keith Ligon, as well as our imaging facility, Carla Kay, and funding from the Society for Neuro-Oncology. So thanks so much for your time, everyone.
Great, thank you, Evan. That was wonderful and so interesting. It's great to hear, a new approach to things, particularly thinking about a more holistic process. So given all the work that you've done in emphasizing the importance of glucose metabolism for glioblastoma, how do we think about our patients who we load with high-dose steroids and who even patients who don't normally have any hyperglycemia have some increase in their baseline glucose levels? How do you think we should approach those patients? How proactive should we be about monitoring their glucose, and maybe how can we rethink how that interplays in their management?
Yeah, that's a good question. So for the steroid issue, Ken Pitter's research at MSK and his MD PhD showed that DEX alone can actually reduce survival of these GBM cells in animals, but also in humans. And that's from probably a separate reason, but the issue with hyperglycemia, I think, is really important. So I think the main thing to think about is not only is hyperglycemia generally bad for these tumors and for these patients, but you also have to keep that in mind with aspects of therapy that are specifically predicated on metabolism of glucose. So yes, in normal patients, high glucose levels that are trickling around can actually fuel their tumor, and that's been shown in a variety of systemic cancers. So, in general, for patients with cancer, I would definitely advocate for a more low carbohydrate diet. They don't necessarily have to be on a ketogenic diet or be in ketosis, but they should try to minimize added sugar, high fructose corn syrup, which we know from our lab can also fuel the growth of colon cancer. But they should try to avoid any type of regimen or diet that can elevate blood sugar levels. So with the hyperglycemia that's induced by steroids, obviously most of this occurs in the hospital at times, and patients are given insulin. So one thing that I think we really need to rethink is the use of insulin as the first line for management of hyperglycemia in the hospital. Patients' oral anti-hyperglycemic drugs are generally stopped, and that should not be the case. They should minimize the use of insulin, because even in patients whose tumors may not be totally dependent on PI3 kinase, insulin can fuel the signaling through a variety of receptor tyrosine kinases. And so just having more insulin around is really detrimental to the patient and can really fuel the growth of these tumors. So I think that's important to be mindful of. And the other thing is that the frequency at which we give steroids, giving it less frequently may also mitigate some of the hyperglycemia that occurs by giving it even every 8 hours or every 6 hours. So that's another thing to think about. So what about the ketogenic diet just in regular patients with GBM? Now, most of these single target studies with this diet have failed. And that's probably because, again, it's not enough to just lower the glucose levels. So just having normal glucose levels will not really prolong survival of these GBM patients because they can use a variety of other pathways. But with this particular regimen, the PI3 kinase inhibitors really try to mobilize the glucose from the liver that is reduced by adding the ketogenic diet. So this is a very specific mechanism of resistance that can be adequately leveraged by the ketogenic diet. Now, there are other therapies that are taking advantage of glucose metabolism or, for example, glutamine metabolism, and those are being tried in clinical trials. Now, back to that schematic that I showed, if you actually starve a cell of glucose, but also simultaneously starve the cell of other amino acids that are critical for metabolism, like glutamine or glutamate, you could potentially achieve more efficacy. So those are other therapeutic considerations that are being taken into account in clinical trials right now.
Hey, Evan, this is Rohan. Great talk.
Yeah.
Quick question for you. You mentioned P10 in sort of the orchestration of all this. I mean, most GBM patients deleted, and you mentioned some mutations. So I was curious what the alterations.
I meant alterations like deletions. Yeah.
Okay.
Yeah. So both tumor cells that we use, they both have P10 deletion, and then also the model from Eric Allen also has P10 deleted. So they're both very PI3 kinase dependent, and those are generally the tumors that are used in these PI3 kinase inhibitor trials. And I know there's also another trial that's basically starting now up with Patrick Wen with GDC 084. And in that trial, they're also looking at the same PI3 kinase alterations that were used in the Viparlisib study. So, that also shows that most patients that we see with P10 or PI3 kinase altered or deleted in 80% of cases are going to be really sensitive to insulin because they're so PI3 kinase dependent. So I think, and the other thing, which you guys probably have all seen, especially you, Rupa, at MSK, is that they often have a candy cart come around, on the holidays that brings, sugar sweetened foods and candies to the patients, which I think is one of the worst things to do in a cancer hospital. We really should be the stewards of preventing cancer patients from having high glucose foods, because really that is just counteracting everything that they're trying to do in the hospital by treating cancer. And the same may be true at Cornell with the food that's given from the cafeteria, as well as food that's brought in to patients to try to minimize candy and sweet pastries from being given to these patients, which can really be counterproductive. And actually, one more thing that I'll mention about that is that the timing of food is also very important, right? So BCAM 120 leads to hyperglycemia in a time-dependent fashion, really starting within minutes of administration and lasting probably about 6 to 8 hours, but that can depend on the patient. So if you're going to try to minimize the hyperglycemia, it really needs to happen immediately. And you potentially would have a window where you could have, let's say, more glucose-heavy foods later in the day after that glucose peak ends. The main point is to try to minimize that glucose peak as much as possible, because during that time, you're going to get the incomplete inhibition of the pathway. So the timing of food administration is also very important. You may consider taking BKM-120 on an empty stomach so that you minimize any other food being around that could then contribute to hyperglycemia.
And Evan, you talked a little bit about neuroinflammation. You know, PI3 kinase has a lot of downstream effects, and one of the things I think it's been implicated in is you know, immune regulation. How do you think that plays into this, and is there, you know, what are the effects of a PI3 kinase inhibitor on overall immune-mediated responses?
Yeah, well, so that hasn't been demonstrated yet. We would be the first to do that. That's kind of how we added to the study previously done in our lab, not only showing that these inhibitors can be synergistic with the diet, but they can also alter the immune phenotype. So what we've been doing so far is we actually took tumor tissue from our genetically engineered mouse model. I didn't present that data today, and we looked at immune cell infiltration, and we see typical sort of T cells, very little, more macrophage, microglia, and some dendritic cells in this tissue. And what we're going to do is treat these animals with BKM-120 and a ketogenic diet to see whether or not there are any changes in this immune milieu. So what we hypothesized based on our in vitro data is that there probably will be an altered phenotype, probably more towards the pro-inflammatory kind that leads to those cytokine production that we see in vitro, as well as the reactive oxygen species that are produced and that neurons experience. So there haven't been any studies really looking at that in the brain. We do know that the ketogenic diet itself in patients systemically can be anti-inflammatory. And there have been a variety of studies published recently showing that they lead to a more anti-inflammatory T helper cell phenotype. And they can also modify the gut microbiome to make it more anti-inflammatory in work that was just published, I think, about 2 weeks ago in Nature. So we hypothesized that since this ketogenic diet is so anti-inflammatory, and we think that the PI3 kinase inhibitors, by leading to hyperglycemia, can be pro-inflammatory, that they may counteract.
Hi, Evan.
Yeah.
Nice talk. I have a couple of questions. The first one is the neuroinflammation that you see with the cortical neurons that were treated with the conditioned medium. Have you guys done cytokine profiling of the medium to figure out what the secreted factors?
Yeah, that's a good question. Yeah, we didn't do that yet because we wanted to look in vivo first to see what cytokines were most produced in the CSF, and then take that back into culture to modify the inflammation that we see. We figured that the in vivo model is probably more realistic, and that we can then better test in the cortical neurons in culture in experimental fashion to, for example, block the production of those cytokines, or use binders that prevent those cytokines from being transferred onto the neurons, and then block the reactive oxygen species. So I anticipate that it's some of the cytokines that we measured in the first set of experiments, for example, interferon gamma or TNF alpha, or for example, IL-1, but we'll confirm that in the CSF.
Excellent. The second question is, what is the IDH1 status of your current models and the future models?
Yeah, so the 603 cells, the anaplastic oligos, are IDH mutated, but the 667s are IDH wild type.
Got it. Okay, great.
And the GEM model is wild type as well, obviously.
Okay, all right.
Great, thank you so much, Evan.
Okay.
Wonderful to have you, and we'll all be seeing you around.
Okay, well, thanks for the invitation again.
Great. Yeah. Bye, everyone.